Let's talk about endodontics with a single drill method. It's very efficient and also much simpler than multi-drills or certainly hand files. This video is on endo technique with a single drill. If you want to see a lot of other videos on endodontics and every other dental procedure, hit the blue link in the description below. So you can see here I've done endodontics on the cuspid and the first bicuspid, and these are provisional crowns on those teeth. You can see the decay into the nerve of the tooth, and the thing to remember is there doesn't necessarily decay does not necessarily have to be into the nerve of the tooth. Think of the objective of treatment. The objective is when you finish a restoration, the tooth is not sensitive, the patient can chew on it, they can eat hot and cold things and not have pain. So there are times when say a restoration is just deep, but it's not quite into the nerve of the tooth, and endodontics may be part of the treatment just so the tooth is comfortable and the patient can eat and drink hot and cold things and apply pressure to the tooth, and it's not sensitive. Periodically, you'll have an endodontic tooth that's sensitive when the patient taps it on the side. This has something to do with the periodontal ligament, even if the endodontics is done very well. It won't be painful when they bite down on the tooth, but if they tap it on the side, it's uncomfortable. And in those cases, just tell the patient, don't tap it on the side. Now, it's very important with endodontics that you do not have eccentric contacts. You don't want them to contact on the final crown when they move into right and left eccentric movements. They only want to hit on the tooth when they bite straight down, and you don't want that endodontically treated tooth to be in hyperocclusion, especially during the first few months after you've performed the endodontics, because the periodontal ligament may be a little inflamed where you've cleaned the canal. You can see this is the first bicuspid, this is the second bicuspid, and there's decay here, and then here's the cuspid, and you can see all the decay here. So we'll be performing endodontics on the second bi and the cuspid. I'm giving the patient a routine block, and then I'm going to give them a intraligamental injection. The intraligamental injection is very important. It's most important if you want to achieve profound anesthesia, if you're doing something like endodontics or an extraction or even a crown preparation. If you're having trouble getting patients completely numb, you're not giving an intraligamental injection. And the way that's given, you can refer to this video. Turn the bevel of the needle toward the tooth, slide it into the sulcus, and this is Sitton-S plain local anesthesia with a 30 gauge needle, and then apply just firm pressure for about 20 seconds. And sometimes I'll give that on different sides of the tooth. Now this is after you've already given an inferior alveolar nerve block, so they don't feel the intraligamental injection. And if you do that, those teeth will be dead, profoundly numb, and your patients will love you. Now here again, here's the intraligamental injection into the sulcus of the cuspid after giving the inferior alveolar nerve block. And this is the rubber dam placement. You can refer to that technique. It's very simple rubber dam placement. Now I'm finding the canals with my Explorer, and this is just a Brasileir burr, and here I've found the canal. You see the canal here and here, and I've removed all the decay, and then I'm measuring the tooth with my computer application, and you can see that this reading is 18.18 on number 20. On the second bi, 18.18, and then on the other tooth it's 20, what was that, 25? So I want a general reading before I use my apex locator to get a more precise reading. So this is a number 10 K-type hand file, and I'm measuring this length, and it's an approximate length, and I'm putting that to place and filing and then irrigating and then putting it to place again. Now if you don't get a good reading, or if the number is jumping all around on the apex locator, it may be because there's fluid in the canal, and so dry that out so that the fluid's not in there. So here's the apex locator on the hand file, and it measures 0.9. You would like the final, the gutta percha cone to be placed to within 0.5 millimeters of the apex. And so if this is 0.9, then I know I need to file about 0.4 of a millimeter further into the canal. Here's the reading on the cuspid, and it's also within 0.9 of the canal. So I know I'm going to file both of them about 0.4 of a millimeter further into the canal. So I'm irrigating. This is a 3-to-1 water to sodium hypochlorite solution. And you want to leave this in the canal while you're filing. So this first part is just hand filing. Now you remember why we hand file first. If you're using rotary drills, from time to time, it shouldn't happen very often, but from time to time, you will probably have a file separation in the canal. If you have filed the depth with a hand file, a 10 or a 15 hand file, and irrigated, either a K-type or a headstrom, and I use both, and cleaned it out thoroughly, then the drills are just being used to expand the canal just a bit. And so if you should get separation and it's filed and irrigated well, then it's not a problem if you have a separated file in the canal. It's actually like an old silver point endo procedure, and I've got some of those in my practice that have been there 40 years. It's really a pretty complicated thing to remove a separated file from a canal, and you can actually damage the root of the tooth. So just be sure before you start using rotary drills that you file the canal out well to depth with either a K-type or a headstrom hand file, a 10 or a 15, and then irrigate it well with the water to sodium hypochlorite solution. So if you should get a file separation, it's not a big deal, and chances are you can just leave it just like that. I'm not encouraging separation of files in canals, but it's just one of those things. It's probably going to happen. You need to inform the patient, tell them that this should not ever cause a problem, but if it did, you could go back in and remove it, or you could perform an apicoectomy with retrofill, but it's better if you can just leave it like it is, as long as you've cleaned it out and irrigated it real well. You can see I'm hand filing here to depth with the K-type and the headstrom. These are the purple ones. Then, this is a fantastic new method that Brasileir Real World Endo has come out with. You use one file, this crookedy file, it's called a XP3DS, to file the canal, and it files it to a size 30 and really cleans it out well. So you don't have to use multiple drills. You're just using this one drill, the XP3DS. So I'm measuring the length here. Be sure the canal is filled with the dilute sodium hypochlorite. And it's very sturdy. It's very hard to separate this file in the canal. So you still don't want to put but just a little bit of pressure as you go to depth, and slowly put it in the file, in the canal as far as it'll go, then pull up, then put it as far as it'll go gently and pull up, and you slowly work your way down the canal. And because it's all bent, it really cleans that canal out very, very well and symmetrically. And this is the handpiece. So you can see I'm going, it catches a little bit, then I pull up, filled with sodium hypochlorite diluted with water. You see that stop to this level is the proper depth. I'll go to depth and then clean that out with the sodium hypochlorite solution. Clean that out and then drill a little more. Just light pressure down until it just catches and pull up, then light pressure till it just catches and pull up. Again, it's a very sturdy file. I've never had one of these files separate. And I've been using this technique with the single drill for about a year. I'd used the multiple drills for many years. Now we're doing the same thing in the cuspid canal. Go to depth and just light pressure. The canal is full of the dilute sodium hypochlorite solution. Then I'm going to irrigate it out, then drill some more, light pressure to depth. And see, I don't have a stop on here because my depth is the bottom of this ledge. So I know when that length to this level right here, I know that's the proper length. There you have it right there. So just to depth and then light pressure to depth and pull up. And that's a perfect 30 gutta-percha cone expansion. You don't want to over-file the canals because you're losing valuable tooth structure and you can weaken the tooth. Remember, when you've performed endodontics on a tooth, it gets more brittle anyway. So you want to save all the tooth structure that you can. You combine the endo procedure with a crown prep and you're reducing the width of the tooth and making it more prone to fracture. That's one of the downsides of endodontics, but endodontics is a way of saving an otherwise hopeless tooth. Irrigating with our sodium hypochlorite solution. Now this is just local anesthesia with a 30 gauge needle. There's nothing magic about the local anesthesia except it's sterile, and you're cleaning out the extra sodium hypochlorite and any other little bits of the grindings from the canal. I'm just cleaning, using this as a cleaning solution. So here's my 30 gutta-percha cone. I'm putting those to place, taking my gutta-percha radiograph prior to cementation. You can see that's just right. Apex is here and here. Then I'm irrigating again with the sodium hypochlorite solution, then the local anesthesia and 30 gauge needle. Then I'm just blowing the bulk of the liquid away from the top of the tooth, and then I'm drying the canals with the appropriate paper points. And I normally place 2 to 3 paper points in a canal to dry it. Then this is the Endo Sequence BC sealer, and the tip of that is real tiny, and so I'll take some scissors and cut the tip off so it's the orifice of the tip is a little bit larger. And then I put it in the canal and squirt. Now I'll give it one pretty firm squirt to be sure it gets to the tip of the canal. And then I'll raise it up as I put just medium pressure, and I'm raising it out of the canal and filling the canal up with that BC sealer. Remember, it's the sealer that seals the canal. It's not the gutta-percha cone. I'm raising it just straight out, and then when you place the gutta-percha cone, place it straight in the canal. Don't move it up and down, because if you do, you could incorporate air bubbles. Just place it straight into the canal. Same thing with the cuspid. Give it one good push, kind of a firm push, to get the sealer all the way down to the apex of the canal. And then just lift it up, squirting very lightly as you come up the canal. And placing the gutta-percha cone. This is my Endo Pro 270, the heating element that just sears off the coronal part of this gutta-percha cone. And I'll sear it off, and I'll just touch down into the canal just a little bit to soften the top part of that seared gutta-percha cone. Same thing here. And then using a plugger to just gently plug that into the orifice of the canal, the softened gutta-percha cone. Then this is IRM, just a little bit of that in the canal. I've used this for 40 years. It was taught to me by an endodontist back in the day, and it's very effective because it's easy to place, and just use it as a buildup. It sets up quickly. So whenever you're using the IRM, you want to mix it pretty thick so it's not mushy. You want it to be fairly firm. So mix a lot of powder with the liquid. This is a wet cotton tip applicator. Crown preps. This is not a crown and bridge video, so I'm only showing the endo. In this video, we'll show the crown part in another Dental Minute video. Here we have it. Good fill, good seal. That's the Dental Minute. These techniques work, and they work every time.